Hello, I'm Doug Mayers. Today I'm going to talk about active site polymerase inhibitor nucleotides, or APSINs. As my disclosure, I'm a co-founder, employee, and shareholder at Antios Therapeutics. As you know, there are many challenges to treating chronic hepatitis B. It's currently an incurable disease that requires lifelong therapy to maintain viral suppression. The reservoir for this virus is cccDNA, which is a stable episome in the nucleus of infected hepatocytes. Current nucleotide agents effectively control replication, but do not eliminate cccDNA in the majority of patients. Only about 5% of patients can stop nucleotide agents and have a functional cure with control of their virus. The remaining patients will rebound within 12 weeks of stopping the agent, implying there's low-level replication occurring in the liver that cannot be detected in the blood with current agents. So we need new mechanisms of action to complement the activity of these drugs to try and attain a functional cure in a higher percentage of patients. The conventional nukes are chain terminators. They get added to the growing DNA chain, and they cannot have the next base added on. Entecavir blocks protein priming and chain elongation, and tenofovir blocks primer elongation and chain elongation in the liver. APSINs have a novel mechanism of action. Their active moiety is the nucleoside triphosphate or clevidine triphosphate, but it does not chain terminate and it cannot be competed out. It acts by distorting the active site of the polymerase, which was demonstrated by investigators at Gilead in 2013. By doing this, it blocks all the polymerase functions, priming, elongation, and DNA synthesis without chain terminating. It is additive to synergistic with the nucleoside agents in vitro. Clevudine demonstrated potent anti-HBV activity in the woodchuck model of hepatitis B. With 1 month of treatment, it decreased woodchuck hepatitis DNA, replication intermediates, and S antigen. And for a month after treatment, there was a continued decline of surface antigen and DNA. Additionally, the levels remained well below pre-treatment levels in the woodchucks for 6 months off of treatment. In 30 months of treatment, in 30 weeks of treatment, you can see that cccDNA levels declined significantly in the woodchuck, declining from 9 to 63 copies per cell before treatment to less than 1 copy per cell after 30 weeks of treatment. This was proportionate to ALT levels and hepatocyte cell death, supporting a mechanism of hepatocyte turnover for loss of cccDNA. Clevudine was initially tested in the clinic in Korea in 2 6-month studies in e-antigen positive and e-antigen negative subjects. It showed very potent on-treatment activity and showed reductions of 100 to 1,000-fold 6 months off treatment, which were unique. Additionally, investigators noticed there was only a very gradual return of HBV DNA toward baseline without the flares that have been seen with other nucleotide agents. Clevudine development was halted when they detected a small number of reversible skeletal muscle myopathy events in patients in Korea in the 2nd year of dosing. These events never occurred before 9 months of dosing, or about 1% at 1 year, but would have progressively increased with extended dosing. ATI-2173 was developed as a phosphoramidate prodrug of clevudine in order to keep the potency and antiviral activity of clevudine, but dramatically reduce systemic exposure, reducing the risk of side effects. The way it does this is shown in the slide below in a rat model. And what you can see is that with clevudine in orange, that the clevudine gets into the portal vein and then washes quickly out of the liver if it's not phosphorylated into the systemic circulation, leading to a high exposure to clevudine. ATI-2173 enters the liver as clevudine monophosphate. Therefore, more of it's ion trapped. More of it goes on to become clevidine triphosphate, as is shown on the left. Clevidine cannot get back out of the liver until it's dephosphorylated from clevidine triphosphate to clevidine. And so you can see that with ATI-2173, there's a 5-fold reduction in systemic exposure to clevidine, along with the increased clevidine triphosphate in the liver. This is PK data from our 1-month study of ATI-2173 in HBV-infected subjects. As you can see, ATI-2173 is rapidly cleared from the blood in 4 to 6 hours. Clevudine does build up over the first week or two of treatment, as is seen with other phosphoramidate nucleoside prodrugs. And what you can see is that Clevudine C-min of the original Clevudine was 56 nanograms per ml. The orange is our 25 milligram dose of ATI-2173, has 13% the original exposure of Clevudine, and blue is the 50 milligram dose of ATI-2173, which has 1/3 the exposure of the original Clevudine molecule, indicating we have a significant reduction of systemic exposure with ATI-2173. This is the antiviral data from that study. And you can see that we reduced hepatitis B DNA by about 2.7 logs in this study after 28 days of dosing, and got 9 of 11 patients below the limit of quantitation, or less than 1 international unit per ml at the end of treatment, as compared to 0.7 log increase in the placebo group. There's a strong desire to look at cccDNA activity in the liver, but this would require a liver biopsy. Investigators have been developing new biomarkers for cccDNA activity, and pregenomic RNA has been determined to reflect cccDNA activity in the liver. With 1 month of treatment with ATI-2173, pregenomic RNA was reduced by 0.6 of a log, and 2/3 of the patients were undetectable after 1 month. As you can see, similar to what we saw with Clevudine, the levels continue to drop 1 month after treatment, where we now have about 0.9 of a log reduction, and 100% of the patients are now undetectable in the arm. The patients remain undetectable after 3 months and then gradually return to baseline, showing a potent effect on pregenomic RNA of ATI-2173. This just compares our off-treatment relapse rate for patients who are undetectable after 1 month of treatment to tenofovir and capsid tenofovir cohorts. As you can see, at one month off treatment, all the patients remain undetectable. At 12 weeks, 44% of the patients remain undetectable. And at 24 weeks, 1 of our patients was still undetectable with only 1 month of treatment. The other curves in light blue and dark blue show tenofovir-treated cohorts who had extended dosing with tenofovir or tenofovir and a capsid. As you can see, by 1 month, there are significant rebound is occurring, and by 12 weeks, 95% of the patients have relapsed. This demonstrates the potent off-treatment effects seen with aspirin molecules. In conclusions, aspirins inhibit all polymerase functions without being incorporated into HBV DNA. It's a distinct mechanism of action from the current chain-terminating nucleotide agents. ATI-2173 is additive to synergistic complementary HBV mechanisms of action. The ATI-20 aspirins have demonstrated potent anti-HBV activity and prolonged off-treatment HBV suppression with a very slow rebound that reduces the potential for an hepatic flare. By liver targeting the next generation aspirin, ATI-2173, we've gotten good hepatic exposures with lower systemic exposures to Clevudine, potentially reducing the risk of off-treatment effects. Combining ATI-2173 with chain-terminating nucleotide will allow us to more potently shut down HBV polymerase and potentially lead to higher functional cure rates. We believe that future combinations for HBV cure will include aspirins because of their unique mechanism of action and prolonged off-treatment responses. We'd like to thank our patients and investigators who participated in our studies, and I'm happy to take any questions at this time. Thank you.